Hello, welcome to Birth Vibes by BirthRight. I am Dr. Himabindu Annamraju, consultant obstetrician and gynecologist at BirthRight in Financial District. Today I have with me Dr. Pallavi Chalasani, who is a fertility consultant at BirthRight. We're going to be discussing a very interesting topic today, which is about recurrent pregnancy losses.
Thank you, Dr. Himabindu, and hello to all the audience. This is nice to have a recurrent pregnancy loss as our topic because there's a lot of unawareness about this topic and a lot of fear going on in all the patients or the audience. So I think this podcast is going to be great that we can remove those fears or get some awareness about this topic.
That's right. It's a very sensitive topic and couples are quite scared when we talk about recurrent pregnancy losses. So how do we address that?
So the recurrent miscarriages or recurrent pregnancy loss is a term and is coined when we have 2 or more miscarriages. Okay, prior it used to be 3 or more miscarriages when a doctor used to intervene, but now we generally intervene after 2 miscarriages to get down the fear and to make people know that we are more supportive and we can treat them better.
That's right. So just knowing that we will investigate after 2 miscarriages makes the couples quite reassured.
Yes,
that they don't have to wait for one more poor outcome.
Correct.
Yeah. So how do we support these women?
So basically these women are already stressed and they take it to themselves that it is all their fault or they're doing something wrong by lifting some weights or doing an extra strenuous job or doing their own office work too much or all the stress factors. So they think that it is that which has caused this recurrent pregnancy loss. But there are n number of factors which actually cause recurrent pregnancy loss, which we really want to get through now.
That's right. So what kind of causes do we normally see in these cases?
There are multiple causes which causes this recurrent pregnancy loss. First and foremost, it might be just a blood correction or blood problems like, the hemoglobin going down, the thyroid issues or diabetes or just the prolactin levels being high. So these are the minor causes. The other causes can be much bigger.
Yeah. So once we correct these simple causes, like whatever, like you said, hemoglobin or thyroid or diabetes, simple causes, then how do we go into the detailed investigations of more complex medical causes?
There are more complex medical causes wherein you do a simple ultrasound to find out the uterine problems. There are multiple uterine problems. It might be just a fibroid sitting there or it might be adenomyosis. That means it's just swelling of the uterus or it can be a septum. It is an extra growth in the cavity or it can be a polyp, which is also an extra endometrial tag. These all factors also cause recurrent pregnancy loss. These are the uterine factors. There are other factors also wherein we have to look into, like thrombophilias. These are coagulation problems. These are blood problems basically. Or we have other problems like
genetic
hormonal problems like PCOS or genetic disorders, which we generally do it in the last.
Yeah. So when we identify a uterine cause, it's important that we treat it. And like you rightly said, can be a simple fibroid, can be adenomyosis, can be a little polyp. When we find any of them, it's important that we treat it, remove the polyp or the causative cause.
Correct.
Yeah.
So there are only simple tests which we can actually see whether the lady has some uterine problems. Just a simple 2D ultrasound, 3D ultrasound. Probably if you find something deeper, you can do an MRI to confirm the diagnosis. There is a simple test which is called sonohystogram, wherein we just inject some water into the fluid. It is normal saline in medical terms. So we inject that to see if the lady has any polyp or endometrial, adhesions or some, uterine factors like, the septums or something like that.
Yeah. And then if that's identified, yes, we should be able to remove it
Definitely.
and treat it by a simple procedure.
Yes.
Procedure would be either a simple laparoscopy or a hysteroscopy.
Correct.
Yeah. And other than this, I mean, all the things we discussed are mainly about causes we find in the woman. Is the problem always with the woman? Does male factor have anything to do with miscarriages?
Yes, definitely.
Yeah.
So basically, it is always the women whom it is blamed, but there are a lot of other factors also. Just as sperm parameters, wherein there is a DNA fragmentation, or there is some habits which we can actually, the lifestyle modifications, decrease on the smoking, decrease on the alcohol. All this also can cause a lot of changes where women factor is not to be blamed, but also male factor has to be checked.
And do we always find a cause? There are cases where we might not find a cause as well, right?
Yes, 60 to 70% there is no cause generally.
Yeah.
We dig into everything, but still we do not find any cause. So it is generally termed or coined as unexplained infertility.
And does unexplained mean that there is no hope for these couples?
Not really.
Yeah.
Probably a little emotional support,
Yeah.
a little care,
Yeah.
and the tender love and caring, this kind of
All
things.
this
And
makes a
then,
difference.
yes. And whatever little things which you can correct, like your thyroid and simple
Yeah.
things also
Yeah.
can make a lot of changes in these unexplained categories.
Yeah. And in these women, after we correct all of these, if they still don't conceive, is there any role of fertility referral for these women who have recurrent miscarriages?
Yes, definitely. The fertility referral is very, very important because we go through as a protocol. So what we do is, as soon as the patient comes, we go through their blood test. We do a basic scan where we can find out all these factors. And if there is a correction factor, we generally do this laparoscopy or hysteroscopy and correct these factors. And in case we get something else, let's say there is a thin endometrium or some infection, which cannot be seen as an acute infection. It might be just chronic infection in the semen, or it can be chronic infection in the endometrium, which is lying. A small little antibiotic also can make a lot of difference.
Yeah. And beyond investigating, is there any specific fertility treatment options you would be able to offer?
For RPL cases, generally we do not go or jump into major things like ART procedures like IUI or IVF. But still, the problem with them is they're actually getting pregnant.
Yes.
But they just need some support where they are losing a pregnancy. So probably that support might be just giving an antibiotic or just giving a support medication which promotes a pregnancy. Or if in case we find some genetic factors, that is when you actually have to intervene with your ART treatments. Probably that might be a little later.
Yeah. And in that point, when you do your ART, you would select the embryos.
Exactly. If we find some chromosomal problems, let's say a couple has come with some RPL problems, recurrent pregnancy loss, and in these patients we find some genetic problems, either in the parents, one of the parents who are just have carriers or something like that, or if there is a proven baby, first baby who has an abnormality, which is proven to be a chromosomal problem. In these cases, definitely IVF would be an option, wherein we can select these embryos through a test called PGTA. Wherein we select these aneuploidies and we remove those aneuploid embryos and we have a good euploid embryos. So yes, definitely the recurrence rate comes down.
Yeah. So with all of these, we will hopefully be able to get a successful pregnancy for these women.
Yes.
Yeah. So if a couple has taken fertility treatment and conceived, then what is the rate of miscarriage after fertility treatment?
Yeah, this is what is a question generally asked in the clinics by the patients. They say that, do we have more miscarriage rates or do we have more abnormal baby rates when we undergo something like a simple IUI or an IVF case? But the actual thing is that a normal person or normal general population has 5% abnormal pregnancy, even if they conceive spontaneously, and 5% miscarriage rate also. So the same rate is there for the IVF or IUI pregnancies as well. It doesn't increase nor decrease. So because it is inbuilt genetically that 5% we cannot change and it is there. And we really do not do anything different from a natural conception that it gives an abnormal conception or it makes some recurrent pregnancy loss. So it generally doesn't happen with IVF.
And for somebody who's had already multiple miscarriages, do they have a higher rate of miscarriage next time?
Yeah, definitely. See, person who has a higher miscarriage rate will obviously have more miscarriage rate when compared to the normal person. It might be just 5%, but 95% they still can have a healthy baby and take home baby.
And what would you say to a couple who has come for fertility and they ask you, what is the percentage of success that they will actually take home a healthy baby?
See, generally, the success rate depends on what kind of treatment we do. Either if it's natural treatment that we're just giving some tablets to help them to ovulate, and then it is time relation, probably that would be around 20% success rate per cycle. And then if it's an IUI, which is an add-on, wherein the sperm gets injected into the uterus of the women, it would be 30%, something like that. And then if we do an ART in a normal people, like let's say person who has a good number of follicles, in them the success rate would be somewhere around 60%. So the success rate of pregnancy doesn't depend upon how many miscarriages they have. 5% they definitely have more miscarriage when compared to general population. But the success rate depends actually on the treatment which we select for them.
Yeah, and also the background risk and other health condition of the couple.
General condition of both male and female. As well, there are other conditions also like the uterine factors, tubal factors, male factor, and their habits, lifestyle, everything makes a difference.
Yeah, okay. And for someone who has had multiple miscarriages, would there be any additional treatments you can offer along with fertility treatment? And if so, how would you select, like to which couples would you actually offer them?
See, there are multiple adjuvants, or that's what we call it as. It's just an add-on, let's say add-on treatments. So these treatments, we generally go on to these treatments when we find a cause. Let's say we have found some thrombophilias, which is a coagulation disorder. In such cases, a blood thinner, which is just a tablet, which is called Ecosprin, or a blood thinner injection, which is called Clexane or heparin, low-dose heparin can be added to these people. Or in case there is some problem with the endometrium, let's say they have some infection, probably that infection can be just cured off with, antibiotics. Or there are other adjuvant treatments. The body always tries to reject, even in IVF or whenever we do an embryo transfer, the rejection capacity of the body is mainly because of their fighter cells. These fighter cells can be decreased by giving them something called a intralipid drip. That's nothing but it's a soya based drip. It is just a nutritional drip which we give. We generally give it in the pediatric department, wherein the natural killer cells, these are the cells which try rejecting whatever we put it into the, like this happens when we do a kidney transplant, when we do a liver transplant and things like that. So those cells which actually, reject things, those can be decreased by using such kind of drips also. So yes, but all said and done, it is not evidence-based proven medicine, but we still practice it and there are good results with them. There are some other tests or, there's something other treatment which is called endometrial scratch also, which is an old school of thought. What we do is in the prior cycle, before placing the embryo, we do a little endometrial scratch in the prior cycle. Let's say somewhere around day 20 or day 21. What it does, it gives an inflammation of the endometrium. So these inflammation actually has more implantation rate. So that is one school of thought. There is one more test which is called ERA. In ERA, what we do is we find the exact window of implantation. So that's the last resort when somebody has multiple miscarriages, let's say more than 4 miscarriages, and we're not able to find any supportive documentation or supportive pathology where we can treat, and then when it all goes unexplained, probably these are the add-ons where we can do something to the patient, so that we actually show them there is a difference on how we treat.
Yeah, okay. That's very good, interesting things to know. Thank you, Dr. Pallavi. It was fascinating to talk to you about this very sensitive topic. I hope our audience has also enjoyed listening to us. So, if you or anyone you know has undergone miscarriage or recurrent miscarriages, there is a lot of help available that we as a team can provide as gynecologists, obstetricians, and fertility specialists. So please don't hesitate to reach out to us, see us, and we will be able to help you. So we'll be looking forward to more episodes of BirthRight, so please stay tuned.